Right, there we go. Right, so I'm going to talk a little bit more about, so John's presented the main evidence around mortality benefit, but reconfiguration of smaller rural and remote hospitals is also done, as John said, for a whole series of other reasons. And so I'm going to run through some of the other assumptions of why reconfiguration is a popular policy. And in fact, it's been the main direction of policy travel in many countries over the last 30 years. And I thought to start off with, it would be really useful to touch upon the outcomes from the previous reconfigurations of emergency medicine that occurred in Canada. So there were reconfigurations from the late 1990s into the mid-2000s in Canada. This was done on a regional basis. The form of reconfiguration was different in each province, and whether or not it was attached with other structural change also varied from province to province. So in some places, it was accompanied by quite major changes to the way that hospitals and practitioners were paid. There were differences in the amount of care that was done with this. And in some places, there was quite good care to ship resource from very small hospitals, which were basically providing GP family medicine type services, and moving those resources into local community general practice. And there was also some major reconfiguration of maternal care. And so the outcomes of this were assessed. And the overall outcome, as John said, was the standard, well, it didn't kill anyone. So there was no evidence actually that the care was better, but there was also no evidence that the care was worse. And particularly the outcomes on maternal health, particularly the reconfiguration in British Columbia, has been used as strong evidence to say that closing maternity services in rural and remote areas does not harm your population. And I think there's a real question about how well these reconfigurations were evaluated. So my own opinion, having looked at the evidence, is that these were not well evaluated. And there's been some particularly strong comeback on the maternity work. So this has been since reevaluated, and actually the conclusion from the reevaluation is that mothers and babies died as a result of the reconfigurations that occurred across Canada. So actually the answer is, you've already suffered from well thought out, relatively well executed rounds of hospital closures in Canada, and they were not good at population level. Right, so what are the common assumptions about reconfiguration that tend to underpin it? Well, the first of these, as John has said, is that smaller hospitals provide worse care. Well, the simple fact is there is no good evidence that outcomes are worse for smaller hospitals. So this is a series of studies that have been done in England. And again, I appreciate that there are country-to-country differences that sit in this. But in England, there is no evidence that being small, either at whole hospital level or by individual service, that services in smaller hospitals are necessarily worse per se. This also holds true, or has held true in America, that in critical access hospitals, which only have 25 beds, that is teeny-meeny by any version of the way that you look at it, any way that you define a smaller hospital, the care and outcomes in these hospitals per se is not necessarily worse. There are plenty of big hospitals that provide crappy care. The next one is, as John has said, is all patients benefit from specialist care. Well, that simply just isn't true. So this is a cut of data that we did from a study that was done by the Nuffield Trust, which I led, and this looked at smaller hospitals in England. And what we're looking at here is actually a data cut of the 20 commonest conditions which occur. And the simple thing is, common things occur commonly. So what are the top 20 conditions? Well, it's infection. It's some cardiovascular disease, so there are some strokes, there is some myocardial infarction, of which STEMI, requiring immediate intervention, is not the key presentation, and some falling over and that kind of thing. So, and what we found is that in most smaller hospitals, 80% of patients do not need a specialist, and even then there are some arguments about to what extent could very skilled generalists provide services? And in most places, they do provide this. So common things occur commonly, and most patients do not need a specialist. They need good, high-quality generalism. Now, there is some evidence that high volumes, particularly for complex surgical conditions, do produce better outcomes. However, for things outside really complex stuff like neurosurgery or having your AAA, your abdominal aortic aneurysm repaired. Now, I don't want that done at a small hospital. I want that done in a big hospital. But for kind of common barn door surgery, like having your appendix removed or having a lap chole done, or again, having a baby delivered, there is no evidence that high volume hospitals produce better outcomes. So again, outcomes at critical access hospitals in the US, 25 beds, by surgical condition, no difference between CAHs and the Mayo Clinic. Not really anyway. And this is a very interesting, the Nally study, which is below that, looked at emergency abdominal surgery in Ireland. Now, what they did find is that the highest volume surgeons in the highest volume hospitals had the best outcomes. But beyond that, the highest volume surgeons in the low and medium volume hospitals had the next best outcomes. And the worst outcomes were the low volume surgeons in the high volume hospitals. So actually, it's not the volume it's not the volume in the hospital, it's probably the volume of the surgeon that really matters. And you can do high volume surgery in a smaller rural or remote hospital. In fact, you may even do high volumes of surgery in those organisations, because you have to operate every day. As John said, there is a natural assumption that system reconfiguration improves clinical outcome. Now, John has presented some of the evidence for that, but there's also excellent evidence from the USA, which is your closest neighbour. And so the HelahtCare group have looked consecutively at hospital closures, hospital and emergency departure closures across California and across the US. And there is just no evidence that closing these hospitals improves outcomes. And in fact, depending on the way that you cut the data, again, there's evidence that patients die because of emergency department closure. There's a whole series of other issues which are also problematic. And if you look at other studies, it's been demonstrated that closing your emergency department, closing your hospital, increases ambulance time on the road. This increases your ambulance incidence, and there's a trend towards mortality significance in the ambulance itself. It also creates chaos in your ambulance service, because rarely is the resource that's put into the ambulances increased when a hospital is closed. Now, one of the assumptions is if you close a hospital, the patients just don't come. Well, and that might have been true some time ago with a younger population of, kind of hardy farmers who have to have their arm ripped off before they go to the hospital. But with an increasingly ageing population, that's not true. Closing a hospital does not change the volume. The patients just go to the next hospital over, and that creates chaos in your ambulance service. And this is from John's work and others. You've got increase in waiting time in trolleys, and there's a whole series of other forms of operational strain which occur because you now have more patients in your hospital. Now, this is an important one because my understanding is that many of the hospital closures currently happening in rural Canada are because there's not enough staff. And certainly concentrating staff is the underlying premise for the reconfigurations which are about to start across the Netherlands and across Germany. Now, there's only a small number of studies which have been done on this, but unequivocally, the studies have consistently found that when you close a hospital, the doctors and the nurses don't go to the next hospital over. They frequently leave the system altogether. So if you're, so if your hospital closes, it's not your next town over. You can now go anywhere, and you might choose, for example, early retirement, or you might choose something else. And this applies even in very small systems. So there was a study of a hospital closure in New York, and the next hospital is like 300 meters away, but actually most of the staff didn't go elsewhere in New York. Many of them just left the system altogether. The other thing that does occur, and this particularly happens when hospitals are merged, yes, the clinicians do go to the next hospital over, but you know what? They're not very happy about it. And they're not very happy about this for decades, like 20 or 30 years, they are not happy about this. And we found this in my own research. And the unhappiness can frequently spread and become infectious amongst the hospital. So actually the process of merger can take happy staff at one hospital, you put new doctors in it, actually you make everybody unhappy, and then more staff leave. So in fact, you don't fix the problem, you actually make the problem worse at system level through doing this. So closure of hospitals because you think you're going to concentrate your staff in the next hospital, there is no evidence for that, and you might just make it worse. Reconfiguration has no other impacts on the system. Well, as we've started to see, that is just genuinely not really true. Reconfiguration has major impacts throughout the rest of the system and also on local towns. And the one that bothers me the most is the creation of deserts of care. And this has been seen most vividly in the USA, where smaller hospitals close. They say that they're going to keep some community services there, and they do for a period of time. But over time, over usually a period of kind of 3 to 5 years, it becomes harder and harder to keep staff there. So some staff kind of hang on, but then they retire, and they retire, they're impossible to replace. And then all of a sudden, there's no care at the hospital. This has a knock-on effect on general practice services. So we have seen very clearly in England that even discussion around closing a hospital means that the local population increase demands on general practice. The general practitioners can't cope with the change in demand, and so they leave. And then what happens over a period of time is that you've gone from having perhaps care that was hanging on and not that great, but there was some care, to having no care at all. And this doesn't just happen in rural and remote areas. Again, it happens, you can see it happening in cities in the US. There are parts of cities in the USA, such as Detroit and Chicago, where there are no medical services at all. And as John has said, these areas are usually the poorest and most deprived. So it's the inverse care law. There are major economic impacts on towns. So particularly in a small rural remote area, the hospital is the single largest employer in town. And so when the hospital closes, the knock-on effect, the ripple effect across the town is major. So people lose their jobs. They are disadvantaged by taking jobs elsewhere because it costs them more money to travel. More money spent on travel means less money on their pocket, less money that's spent in town, because frequently it's spent now out of town. And there are substantial knock-on effects across the town. The other thing to say is that you can't then attract people into your town, because if you don't have a hospital, why would anyone who wants to plan a young family come and live with you? You know, if you can't provide maternal care and you can't provide child health, why would anyone feel safe coming to live in your town? So the economic impacts on towns can, in fact, over a period of time, can be devastating. And they, yeah. Well, this is Margate, and I referred to the fact that at Margate they just even talked about closing their hospital, and that's just been a disaster. And as John has said, there are major issues around abandonment, injustice, and inequity. And really, nothing fires up a community more than saying that your hospital is going to close. Well, why is that? Well, people everywhere pay their taxes, and in return for paying your tax, you expect civil services. And a key civil service that you expect is access to healthcare. Now, in Canada, this is actually written into the Health Act that there should be social justice when it comes to access to healthcare. And so if your hospital closes, nothing says that your government doesn't love you like your hospital closing. And so it's no wonder that people get angry and upset about this for perfectly legitimate reasons. And the fact that governments then ignore people's legitimate reasons, I think is really, like John, I think is really very problematic. And I think there's a question around dishonest framing in this, which John has alluded to, because the simple fact that clinicians want big, shiny hospitals. Now, the hospital on the right, the really unattractive grey and blue building, that's the hospital where I work in London, which is an absolutely massive hospital. It was the 5th most expensive building at the time in English building history. And it's not a very good building. We spent £1 billion on it for a not very good building. And the interest on the building is £52 million a year. So we are behind financially even before we start. The lovely, beautiful hospital that you see on the right is part of the Danish Super Hospital program. Ooh, shiny. Wouldn't you want to work or be treated there? I would. And so what the clinicians and the politicians want are beautiful, shiny buildings, because that's a vote winner, right? What the patients want when you ask them is that they want the Mayo Clinic at the end of their street. They want high quality care close to home. And again, that's a completely reasonable thing to want. But really, the patients are happy with decent care close to home. So the picture here is of Belford Hospital, which is one of the smallest hospitals in Scotland. It has 33 beds, and there are ongoing arguments about whether or not Belford should close. Well, Belford is not that far as the crow flies from Glasgow, but you can't because it's got foggy weather, you can't get a chopper in and out 30 days a year. The roads are impassable for another 20 days a year. And even on a good day, it's not that far, but it's 3 hours by train and it's nearly 2 hours by car across very, very treacherous roads. And if you're in the back of an ambulance being transferred, for just because you've fallen over and broken your ankle, that's not a great outcome for the patient. Thank you. Any questions?